in our resource link. There we go. Hello. I feel so honored to be among so many talented and creative people. Thank you. And just to say, we're going to go straight into our next session, and I'm going to turn it over to the wonderful Susan Dutton to introduce the session and the speakers. Thanks so much. Thanks, everybody.
Welcome, everyone. Perhaps we'll just wait for a couple of minutes while our speakers turn on their videos and their audio. Perfect. Hello, everybody, and welcome to the session, Research and Clinical Perspectives, Creative Activities and Parkinson's. My name is Sue Dutton. I've been a teaching artist with Dance for Parkinson's in Sydney for the last 5 years. Before we go any further, I would like to acknowledge the traditional owners of all the lands we are joining from today. I'm joining from Wiradjuri country in central New South Wales. I want to pay my respects to their elders, past, present, and emerging, and acknowledge Indigenous and First Nations participants who are joining us today. Firstly, let me just mention that the session is 1 hour and 15 minutes long. We will break towards the end for approximately 5 minutes or so to take questions. The chat function is open and being monitored. So if you would like to make any comments or feedback or ask a question, please just use the chat function and we can take your questions for the end. I'm really looking forward to this session today, where we will be exploring recent research on the role of creative activities and living with Parkinson's disease. We have an amazing lineup for you, and I'm just going to introduce them very briefly, and then I'll be handing them over to start the presentations. So firstly, we have Professor Graham Kerr, who is the Professor of the School of Exercise and Nutrition Sciences at QUT. His research interests involve posture, balance, gait, and falls in older people, and the relationship to neurological disease. Our second speaker will be Dr. TJ Legrand. He is a neurologist currently researching functional movement disorders, I believe at the Princess Alexandra Hospital in Brisbane. Our third speaker is Camilla Pinto, and she has a dance and physiotherapy background. She has subsequently been investigating neurorehabilitation strategies for people with Parkinson's. And then finally, Dr. Nadisha Kalyani, who is a senior lecturer in physiotherapy with research interests in neurological physiotherapy and biomechanics. So that is our lineup for this afternoon. We have lots to cover. I'm going to hand it straight over to Professor Kerr.
Thank you, Sue. Good to see everybody. So I'm just about to launch my talk now and share my screen, which hopefully everybody can see. Lovely to see Nadisha and Camilla and Jiek as well. Good to see you. Okay. Can everybody see that all right? Fantastic. So I'm going to talk at just my sort of brief 10 minutes or so on more of the sort of neuroscience perspective in terms of factors that I've been looking at in Parkinson's disease, as a specific focus on falls and falls prevention. Now, I'm not going to get too scientific, but I'm just going to wave a few flags and just let people know the context which we're approaching things, and so some of the implications for everybody. And later on, I'm sure that both Camilla and Nadisha will be filling in some of the more sort of creative elements that will go into some future interventions. So here's my sort of structure. I'm going to first of all talk a bit about clinical background here. And I guess the first thing I want to just mention is that in Parkinson's, as we all know, is that it's well related to motor symptoms. Everybody thinks about the problems with tremor and not walking properly and rigidity and things like this. But we also know that there are a lot of non-motor symptoms that are also affect function in people with Parkinson's. So can be psychological impairment related to cognition and depression and anxiety, with more rapid dementia occurring. There can also be, problems in cognitive and executive function. So these are particular aspects about neural function, which are related to response inhibition, so stopping you from doing things, monitoring what you're doing, and paying attention to what you're doing in the environment. Now, all of these, of course, all come together in when you're considering falls in people with Parkinson's. And this is a particular issue for people with Parkinson's because it's a very high occurrence. There's certainly well over 40% and sometimes up to 70% depending on the stage of the disease. It's the most common occurrence for people who are admitted to emergency rooms, and it's also the largest contributor to healthcare costs in Parkinson's. The problems of falling is not just the fact that you can get very severely injured and problems with resulting from the fall, is that you develop a fear of falling as well, and the recurrence of falls. So people who have fallen are not so bold in terms of their activity, and there is a loss of independence, and this whole inactivity can lead to earlier onset of depression. The trouble is when you do fall with Parkinson's, of course, you have this occurring. So a person with Parkinson's would fall and they might land on their hip and have a hip fracture, but they also might land so they might actually have a skull fracture as well. So they are very, very severe incidents indeed. And I've now presented a nice busy slide, and this is to indicate that there are multiple factors that affect people with Parkinson's, and all of which contribute to the risk of falling. So we can understand that if you can't see properly, you don't know how to navigate, and therefore you might be at risk of falling. But also other impairments in sensory systems also have an effect. For example, people with Parkinson's, as well as older people, have reduced sense of touch. So interacting with the environment through their feet. There's a reduced sense of auditory function sometimes as well. And of course, there's problems in motor function in terms of muscle strength. Nutrition is also a factor because that has basically the underlying health conditions that a person must have. And things like polypharmacy, for example, being treated with multiple pharmaceuticals can also be a risk factor. So if all of these things in play, we've got a lot of things that we can potentially focus on in terms of trying to reduce that risk of falls. And it's important because the clinical impact of falls is such that the postural instability, the gait impairments, environmental circumstances might induce more frequent falls for an individual, which of course has a resulting injury related to fractures, cuts and bruises, fear of falling developing, which the person then becomes more immobile because they're not so adventurous in their activities. And that can lead to a whole lot of other secondary factors like constipation, muscle weakness, insomnia, social isolation, and osteoporosis. And this is part of what we call the sort of downward spiral, where if you don't break the cycle, you can actually exaggerate all these other symptoms again, postural instability, and it can get worse and worse, which of course means all these aspects about having reduced quality of life, cognitive decline, more rapid disease progression, for example, can all be exacerbated or accelerated if we cannot get in there with the right intervention. Now, we've identified in some of our work too, using some fairly sophisticated motion capture systems, that people with Parkinson's have a lot of upper body motion with respect to their walking. This is relative to healthy older people. So one thing we're actually looking at is how can we actually act to reduce that upper body motion, especially of the head motion during locomotion. Because this accentuated action means that the people with Parkinson's start to adopt a particular pattern of walking. Oops. Akin to what I would call a penguin. So this is actually meant to illustrate that people with Parkinson's don't swing their arms very much. They tend to waddle a lot, and they tend to have very short shuffling strides or actions of the feet in the locomotion, all of course, which increase the risk of tripping and slipping and consequent falls. Now, understanding all of these particular systems has been one of the things we've been undertaking, and so now we have algorithms which actually can predict the risk of falling. So we are now in a position where we have fairly good tools in which we can actually estimate what that risk for an individual is, and therefore take preventive action. So other things that underpin these risk of fallings are facets related to the neuroscience and aging process. Sorry, my screen's just a little bit low today. Slow, sorry. We do know that in people with Parkinson's, there's reduced dopamine in the central nervous system, and this is a function of aging. So you can see here nice bright images here, which shows the dopamine in the healthy young person, and this is in a healthy old person. You can see that's much reduced just by aging. It's even more greatly reduced in people with Parkinson's. We also know in people with Parkinson's that there is a atrophy in the temporal cortices and hippocampal areas, and there's reduced activation in these areas of the brain, the frontal cortex and the thalamic areas, and these are areas of the brain which are involved in executive function or decision making. And what does this mean? Well, it means that with these sort of aspects of cerebral function, underpinning that is a physiology that's changing too. So we know that there are blood flow changes that also are altered in people with Parkinson's and in older people as well. So there's reduced blood flow into particular areas, as seen by all the vasculature here. It is different in older people in Parkinson's relative to healthy young people. And this reduced blood flow is seen in these images here. So in this particular image, which is taken from a study by Sue et al., we can see all the blue indicates a hypoperfusion. That is areas where the blood is not getting to the brain as it should do. Sorry, my screen is not responding quickly these days. What it means is that if these areas are getting reduced blood flow, that means these functional areas are not acting as they should in terms of decision making and control of their balance coordination. We can see also though that there's some hyperperfusion. Some areas of the brain, such as in the cerebellum down here, are trying to counteract some of these deficits. And for you and I, if we have reduced blood flows, this means that we'd have problems doing these tasks like dual tasking, for example, doing two things at once. So Dr. Zeus, or even when you're driving, not that I advocate any of these behaviours, mind you, we would have broken just about all the Queensland road rules if that was the case in here, but doing more than one thing at a time is definitely an issue. And of course, when you're trying to balance and walk and talk and do multiple things at the same time, then this can be a factor for increasing falls. So what do we advocate to try and help keep a person mobile and active in the community? Well, exercise is key to that. And of course, you can go to the gym and you can go and lift heavy weights, like this older woman here is doing, who's lifting 153 pounds, a weight I could never, ever manage to do myself. But that resistance training is really important for maintaining muscular strength, as also is aerobic exercise. That is activity which increases the demand for oxygen. So you want to increase your heart rate and respiration rate. So all of these things are really important for people with Parkinson's to maintain. And we know this from one particular study, and in fact there's a few studies now which indicate this, but this one is quite interesting because this is a group of people with Parkinson's who were divided into two groups, one that got a resistance training, gym-based exercise, and ones who didn't. And what we see here is a score for their, what we call a motor score for their Parkinson's disease severity score. And this is a change from baseline. And we see that after they started training, both groups actually improved their score. That is the gym group and also the control group. But after 6 months, differences started to emerge. So that those who started who stayed in the resistance training group, they maintained a much lower score. That is, their motor symptoms were less severe than those who did not participate in that gymnasium session. And that was maintained for over 2 years. We also see that there are also positive effects on medication from engaging in the exercise too, such that those who are in the resistance training group actually ended up with lower levels of requirements for medication compared to the controls. And that is really important because then you don't have all the negative consequences of increased medications, which can have side effects in their own right. What sort of exercises should you do? Well, they're listed at the bottom here. Multiple types. If you go to gymnasium, you'll find some very ready helpers in terms of that prescription. Now, if we do adopt exercise programs or any type of activity, we have to consider some things. One is your motivation for doing it. So we hope that within the creative areas that is creating a motivation in its own right. sometimes an external motivator can be very useful to get you into the habit again. But once you get there, also try and adhere to the program as well. That's actually really critical. So what can we offer you? So here at QUT, we have gymnasium programs, and we have shown good success with a variety of gymnasium activities for increasing strength across a whole number of different exercises, from chest presses, back extensions, leg extensions, push-ups, leg curls, and leg presses. So very positive effects here, and also an indicator from this work is that that is reducing falls risk too. And the other program, which was kindly worked through with Erica Rose Jeffrey and others, is the Dance for Parkinson's course, which we've hosted here, and which Nadisha will actually most probably tell us a little bit more about later on. So there's my little bit more science orientation in terms of what we're bringing to this session. Thank you very much.
Thank you so much. That was really interesting. Can we hand over now to TJ, please?
Right, I hope you can hear me. I will in a moment share my screen. All right, so can you tell me if you can hear me and see my screen?
Yes, we can. That's perfect. Thank you.
Cool. Sue, thank you so much for the invitation to speak at this mini festival about. I actually, when I looked it up, I saw dancing in Parkinson's disease, and then I thought, well, I'm actually just started with my fellowship. I'm a Dutch neurologist, so that's the accent that you hear. And my Dutch name is Tjerk, but it's very hard to pronounce here in Australia. I discovered that after half an hour. And the spelling is T-Jerk, which was also not so handy. So please call me TJ. Everybody does here. And I think that's far more easy. What I want to say is when I looked it up, I was invited by Graham to give you a small talk about research projects that we are currently doing in Parkinson's patients in PA Hospital, where I work. And I was looking and I saw dancing in Parkinson, and I thought, well, actually, all the research projects that we are currently doing are not typically about dancing, but I think it is also maybe worthwhile to talk you through some studies that we do. It's a little bit more therapeutic based research, but to give you some insight what is currently going on in therapeutical studies in PD. And at the end, I also try to make a connection to dancing, but you will see that in a few moments. First study that we are currently doing is that we are testing a new drug in Parkinson's patients. The drug is called tafepidone. I also have to warn you, all the studies I'm going to talk about are sponsored by pharmaceutical companies. I don't have any interest in any of those companies. I just came here as a fellow, but I think you also always have to take those projects also with a healthy portion of skepticism. But on the other hand, it gives you some insight what we are doing at PA with people with Parkinson's disease. In this study, we are testing this new drug. It's called tafepidone, and it's a new dopamine agonist. And as you might know, still after 60 years dealing with Parkinson's disease, the best and most effective drug that we have is levodopa. It still is. It's around for what I said, 60 years or so. And I think in almost every new patient, we start with levodopa. The brand names of levodopa are here in Australia, they use Kinson, for example, or Medopar. I think that are the two main ones. Cinemet is another form. All those brands are actually drugs with levodopa in it. That's the substance. And what I said, it's still after all those years, the most effective drug that we have, but it comes also with some, well, what a real nuisance is in people who are on levodopa is that it only works for a couple of hours. And in the beginning, for example, we start in a new patient, we start with levodopa 3 times a day. But after a couple of months or years, when the disease progresses, we see that we have to increase the dosage, or we have to increase the frequency. And another nuisance, of course, is when you have to take your medication 3 times a day. You always have to think about, I have to take my drugs with me. If you are still working, for example, or if you are dancing, you have to take your medication with you. And that's why they thought, well, can't we develop a drug that we only have to give our patient once a day? And that are actually the group of the dopamine agonists. And there are already a couple of dopamine agonists on the market. You have Cifrol, for example, which is pramipexole, or roticotine patches. And well, these drugs are also pretty effective in people with Parkinson's disease, but maybe not as effective as levodopa, because it's an agonist. It's actually fake levodopa, so maybe not so effective, and they come with more side effects. So people can develop impulse control disorders with that more easy. Nausea, vomiting is also more common in dopamine agonists. And what the company and what we hope to see in tafepidone, it's a new agonist, and it works different than the other ones who are already on the market. It works on different dopamine receptors in the brain, and hopefully this might be a new drug in the future that we can give to patients only once a day, for example, when they wake up, so they don't have to carry their medication with them the whole day, and that it comes with less side effects than the agonist that we already have. And actually now we're testing this drug in different patient groups. We're testing it in people with early stage Parkinson's disease who weren't on any dopamine therapy before. So actually that are the patients who come to our clinic and that we say, well, sorry, but we think this is Parkinson's disease and we want to start treatment. So maybe if you're keen to participate in this trial, we can trial this drug in you. There's one group of patients. Another group of patients is the patients who are already on levodopa therapy, but having these difficulties of they are already taking the medication, for example, 4 times a day, but it's still not enough. They wear off, so they have more motor symptoms at the end of their time interval between the medications. So they're getting more stiff, and they think, well, maybe I should have my medication a little bit earlier already, and they have to increase to maybe 5 or 6 times a day. That is the second group of patients in which we're testing this new drug. Another study that we're currently doing is a study which is about deep brain stimulation. That's also a thing that we do in PA Hospital. I think you probably all know that at a certain point when the medication might not be work enough anymore, we can go to advanced therapies in people with Parkinson's disease. And one of those advanced therapies is deep brain stimulation. In deep brain stimulation, it's deep brain surgery. So we put actually 2 electrodes in the brain in the areas that Graham already showed who are involved in Parkinson's disease, and actually the patient can ourselves after that they have their own stimulator and they can increase or reduce their power according to their amount of symptoms. And I thought just showing you how effective deep brain surgery can be. This is a patient with young onset tremor dominant Parkinson's disease. Here you can see his resting tremor in both upper limbs. This is before he had the brain surgery. See, the tremor is a little bit worse on the right than on the left. It's also a little bit hypokinetic on both sides, also more on the right than on the left. And this is a video after the deep brain stimulation. And look, yeah, actually this morning we had another patient in which we did deep brain surgery. I'm still sometimes so surprised how effective this can be. Also, have to be cautious with that. Deep brain stimulation can help in people with Parkinson's disease, but it really depends on the subtype of Parkinson's disease that patients have. It works very well for people with stiffness. It works very well for people with tremor. Unfortunately, sometimes we get these questions with patients who have problems with, well, postural instability or freezing of gait, which Graham already mentioned as well. And in those type of Parkinson's patients, deep brain stimulation, we often don't offer it to patients because it doesn't work for those symptoms in the disease that much. And with the Adroit study, this study or this research that we're doing, we are actually looking for how patients are performing before and after surgery. It's a registry that we have to look for short-term and long-term outcomes, as well motor-wise, as well as non-motor-wise, and as well we're looking in for quality of life, for example. Last study that we hopefully gonna start next year is the NUSHU study. The NUSHU or NUSHU, that's where it comes from. It's a company in Switzerland who developed these new shoes for people with Parkinson's disease. Graham told you already about the problems that people can have with gait and freezing of gait, for example, or postural instability. But as you can understand, it's sometimes pretty hard to measure that, because how are you measuring gait? Yeah, you can put electrodes on patients, but are they then still able to walk all day? Or they can keep a diary about their episodes of freezing of gait. That's what we used to do. But to get real 24/7 data, this is probably a solution for in the future. These shoes contain sensors, so people are getting these shoes from us with Parkinson's patients, and they actually 24/7 their gait is measured. So it's linked to wirelessly linked to a computer, and we can see how much they walk during a day, how fast they walk, how much freezing of gait they have, how many falls they have. And of course, that is a lot more objective than when we give people a diary. Not that we don't believe what they write, but this is actually real life data. And what another really cool feature is in this feature, as you might know, in people with freezing of gait in Parkinson's disease, sometimes cues can help. So some people, when they have a freezing of gait episode, they start counting, or they start raising their knees, or when there are stripes on the ground, that can be a visual cue for get over that freezing of gait episode. What these shoes have is they not only having sensors in them, but they also have stimulation, sensory stimulators in them. So people also can experience when they, for example, when they have to raise their leg a little bit more, their right leg, they get a little, not a painful stimulus, but just a gentle stimulus to their right feet, exactly at the moment that they have to lift it, and then they can lift it maybe a little bit more. So really cool. And I think this is one of the things that might improve gait difficulties in the future. And as I promise you to make the link to maybe more dancing and creativity, I'm not gonna say that our Parkinson patients are, when with these shoes, that they are able to do this. but really, I think it might help to improve their gait, maybe a little bit less than in this video of Lord of the Dance. I can't promise you tap dancing in the future, but hopefully improve some of their gait problems. Also, not, as I said, I'm not from a pharmaceutical company. I don't have any interest in any of that. But if you have more questions about the studies that we are currently doing, you can always drop us an email or call us if you want to participate in one of our trials, or if you have questions about my presentation or want to know a little bit more. Please, let us know, and I'm willing to answer all your questions. All right.
Wow. Thank you, Dr. Legrand. That was really interesting and exciting, potentially exciting new developments. So thank you. I'm handing now over to Camilla Pinto. There you go. Thank you.
Hello, good afternoon, I think, for you. Good morning for me. I hope you can see my screen now.
Yes, we can see and we can hear you.
All right, perfect. So it's a pleasure for me to be here talking a bit of what we have been done in Brazil. So let me introduce myself. My name is Camila. I'm a dancer, physiotherapist, and a PhD student from Brazil. And today I'm going to be talking briefly about the project that we did last year in Brazil during the pandemic time. So the name of the project is Online Dance Intervention in People with and Without Parkinson Disease in Brazil, a feasibility trial. So I think we already know that many studies have been showing about dance as a potential intervention and one of the several known pharmacological interventions with much benefits on motor and non-motor symptoms and well-being. However, during the last years, we needed to readjust another way to provide health care for the entire population. And also my project, we needed to readjust what we were looking at in terms of rehabilitation in people with Parkinson's. And we wondered if dance in a virtual environment would be feasible and safe for elderly people with and without Parkinson's disease. So we ask ourselves the question, is online dance intervention feasible and safe for elderly people with and without Parkinson's? So we designed a clinical trial, a non-randomized clinical trial, phase 1, that we registered in the clinical trials, and it was also approved by the ethics committee in my university in Brazil. And we conducted this study last year, starting on August 2020. So we started the recruitment, and we included individuals with and without Parkinson's disease, with minimal cognitive ability to understand commands, and also a stable dopamine medication at the last 6 weeks before the beginning of the study. So after that, we started a pre-evaluation, which we included several demographic characteristics about all participants, and also other questionnaires about quality of life. And after that, we started the online dance classes online. So all participants, they were doing the same in the same group, the online dance class, 2 times a week, 6 minutes each class during 2 months. And at the end, we did the same evaluation that we did before on November 2020. So all this research was conducted using Zoom platform, including the evaluations and also the classes. Here I bring just some of the baseline characteristics of all participants. So we included elderly people with Parkinson's, 13 participants, and 15 participants without Parkinson's disease. The mean age of all was around 70 years old. And also regarding the clinical characteristics, people with Parkinson's had around 8-9 years of Parkinson's diagnosis. And here we can see the primary outcomes that we were investigating regarding feasibility and safety of this intervention performed online. So participants were monitored regarding adherence, attendance, delay of more than 10 minutes, self-distractions, tech barriers, and safety. So here you can see the dark gray is elderly people with Parkinson's, and the light gray is elderly people without Parkinson's. At the first figure, we can see the adherence on this program, which was 100% for both groups. So all of them completed the full intervention program. Next, the attendance, which is the number of class attended, was also high, around 90 and 88 for each group. Not much individuals attended late during the whole intervention regarding the delay. And also, we did not have much self-distractions during the classes as well, as they were performing the dance at their own home with their family and caregivers. We also identified tech barriers related to difficulties on accessing and managing the video conference platform, around 10% for both groups. We also observed internet problems, mainly reporting poor connection, and also a few problems with sound volume, but it was really low, around 2% for each group. So another important outcome that we were looking at was safety. And this protocol was 100% safety for both groups. We were looking at adverse events as cardiovascular events, injuries, near falls, or falls from height. And any of them occurred while participants were performing the dance intervention. So this is an image of one of our classes with all participants during the dance class. I was the one who instructed the dance classes for them. And although the main objective of this study was not investigating the clinical demands, we performed weekly calls regarding their perceptions during the research, and all individuals reported to feel safe while performing sessions and perceived benefits, especially on mood improvement. We also saw good results on questionnaires regarding quality of life after the intervention. So to summarize, online dance intervention is engaged, feasible, and safe for elderly people with and without Parkinson's disease. Importantly, the majority of participants included in this study were able to walk independently, perform activities of daily living inside home, although they required supervision outside home. We had at least one fall in the last year and risk of falls, and a moderate stage of disease severity. Above all, the advantages and disadvantages of online intervention must be highlighted. This approach might be a safe solution for those who live in remote places without specialized group rehabilitation, and also those with a high risk of falls, unable to go outside home or traveling to a venue, or absence of family caregiver on helping them to transportation and going outside home. On the other hand, lack of familiarity on managing resources and devices, and device portability as well, especially for low-income countries, might be some barriers when implementing novel technology. Next step is to compare online and versus in-person dance class in a clinical trial. So hopefully this will be our clinical trial phase 2 of the whole project. And we aim here to verify the effectiveness of both approaches on clinical domains, such as motor and non-motor symptoms and well-being. We also aim to add on our next study the Goldsmith's Dance Sophistication Index. This questionnaire assesses individual differences in dance experience, which we believe that influence the therapeutic effectiveness of dance as an intervention. So this questionnaire is available for English language. And now I'm working to translate and validate to Brazilian Portuguese as well, so we can add in our dance research. I would like to thank all the team involved in this project. My team in Brazil at UFSPA, which is my university, and also Erica Rose for teaching me and helping me to conduct dance classes, the online dance classes. I'm also doing my certification on dance for Parkinson's. So yeah, thank you so much. And I'd like to thank you also to be here and talk briefly about this project. It's very nice to see Graham and Adisha. And I was visiting QT 2019, and the dance program was the first program that I saw. And it inspired me a lot to do this project and bring my dance background to the research academy as well. So thank you very much. And I'm free to, if you have any questions, you can send me an email. And that's all. Thank you so much.
Thank you so much, Camilla. That was really interesting, and we'll look forward to seeing the results of your next studies. We can see that the need for online classes, having done so many through the pandemic, we can see the ongoing need for them. So it's really interesting. Thank you. I'll now pass it on to Dr. Kalyani, and then we'll hand it over to questions at the end. Thank you.
Hello, everyone. Thank you for giving me this opportunity. And special thanks for Erica Rose for inviting. I'm going to provide some details about my PhD research project that was carried out in Queensland University of Technology with a wonderful team of supervisors, including Professor Graham Kerr, Prof. Karen Sullivan, Prof. Jean Moyle, Prof. Sandy Brower, and Dr. Erica Ross Jeffrey. Our study aimed to investigate the effects of dance for Parkinson's disease model, mainly on gait, cognition, and dual tasking in people living with Parkinson's disease. A little bit of history about this dance or PD model. This initiated in 2001 in New York by Brooklyn Parkinson's Group and Mark Morris Dance Group. And then the Dance for Parkinson's Australia began classes in Queensland Ballet in 2013. And the first pilot study was conducted in 2014 as a collaborative research project between QB, QT, and UQ. This study has found that this dance program provides numerous beneficial effects for people living with Parkinson's disease. So our study was actually a continuation of the previous pilot study, and the QT Dance for Parkinson's classes began as a part of this research project. The aim of this study was to evaluate the effects of dance classes based on Dance for Parkinson's disease model, mainly on normal walking and dual task walking. That means walking while engaged in a cognitive secondary task. Then on cognition and psychological symptoms, including anxiety and depression. Then on disease severity, functional mobility, and fine manual dexterity. Furthermore, to objectively quantify the habitual physical activity by measuring the number of steps, time spent in sitting and lying, and so on. And lastly, on quality of life. So this was a feasibility study and had a quasi-experimental parallel group, pre-test, post-test design with a dance group and a control group. The participants had mild to moderate stage Parkinson's disease with no cognitive impairment. The dance group underwent twice a weekly classes for 12 weeks while undergoing their treatment as usual. And the control group just had their treatment as usual. And the classes were conducted by Dance for PD trained instructors from Queensland Ballet. So we anticipated that compared to a single dance style, the improvement would be higher as the Dance for PD model incorporates different dance techniques and cognitive skills. So there were three distinct elements in these classes, the seated dancing, then the standing dancing, and progressive standing dancing. Recorded music was used, and this music was carefully selected by the senior dance teacher, and it ranged from classical to modern. So the dance group and control group both had a baseline assessment and post-intervention assessment. And a comprehensive set of measures were used, which were valid, reliable, and validated for Parkinson's disease. The disease severity was assessed using the the Movement Disorder Society Unified Parkinson's Disease Rating Scale. The biomechanical analysis of the gait was conducted by Vicon motion capture system, and a battery of clinical tests and questionnaires were used to assess the functional mobility. And then cognition was assessed using the NIH toolbox, and the level of habitual physical activity was measured using ActivePal activity monitors. So when moving on to the results, we found a high level of adherence with no adverse effects such as falls. And there were areas that significantly improved, mainly the disease severity, fine manual dexterity, functional mobility, which mainly included balance and walking, the psychological symptoms, mainly the anxiety and depression, and the quality of life. And the findings of the biomechanical analysis of the gait, which was the main focus of our study. In normal walking, there was a significant improvement in the dance group in gait velocity, cadence, that means the steps per second, step length, and stride length on even surface. There were limited improvement on uneven surface walking. For dual task walking, there was a significant improvement in the same areas, the gait velocity, cadence, step length, and stride length, while engaged in serial subtraction tasks and verbal fluency tasks. That means we asked them to subtract numbers from a given number while they're walking, and also to generate words from a given letter, which was really challenging for them. On uneven surface, there were improvements shown in serial subtraction only. Related to cognition, we had mixed results. There was a significant improvement in executive function. However, the remaining cognitive skills did not change. The volume of habitual physical activity exhibited no change in both groups. Eventually, we concluded that the dance classes based on Dance for PD model had clear benefit on gait, disease severity, psychological symptoms, quality of life, and on selected cognitive skills. And it also provided essential data for undertaking a future large-scale randomized control trial. So when we think about the reasons for improvement, there may be a number of reasons for this improvement. These dance classes use execution of dance patterns, and it involves motor planning and memory. And also these dance classes use different attentional cues such as visual, auditory, and somatosensory. And also the components of aerobic mobilization and balance exercises are embedded in these dance classes. And also some of the dance patterns provide opportunity for multitasking, which is why we assume the improvement in the dual tasking has improved. And then overall, it is a pleasurable experience for participants. There is an opportunity for socialization and also facilitate the psychological adjustment of the disease when they meet the people who have the same condition. So as a future direction, the current study could be replicated in a more diverse sample of people with additional parallel groups at multiple sites, because we had to be limited with the PhD timeline, so we had some limitations. However, this could be done at different sites within Australia, and also while multiple benefits were observed, it is still unclear the durability of these effects. So it is important for future studies to have a follow-up evaluation to find whether these effects can be extrapolated to daily life. And also there is a scope to find the effects of music in improving the symptoms of the Parkinson's disease. And also it is important to improve the awareness of the clinicians and therapists to explain and direct the patients to have the most beneficial combination of treatment to have better outcomes. So overall, this research project became a success, and upon the completion of the classes, the participants requested an ongoing class, and the QT commenced an ongoing class for the participants. And also we had a number of conference presentations and also publications in peer-reviewed Q1 journals. And then there were some awards, the Silver Oral Presentation Award at the PPCR conference in Hong Kong, and the Best Poster Presentation Award at Annual Research Symposium, University of Colombo. So I believe that this study has broadened the understanding of the effects of dance on Parkinson's disease and added new knowledge to the existing literature. And also, this study has confirmed that this dance for PD model is successful within the intended population and has a high demand as a therapeutic intervention. Thank you.
Thank you so much, Dr. Kalyani. That was really wonderful news to hear those results. And obviously that's the reason why we teach Dance for Parkinson's, and we hope that exactly the people get those results from the classes. We are now able to ask some questions of the presenters. So if you would like to open your microphones and your videos, we can open up the stage to people. They can ask their questions on the chat session and we can pass them on to you. Perhaps first of all, I might start with a question though, and I might just ask TJ whether you could just respond from a clinical perspective on some of these creative interventions that we've been talking about.
Yeah, I can. Thank you for the question. Yeah, really, really important. I think it's still a pity that with all the new medications that we have, all the new type of advanced therapy that we do, there's still not a cure for Parkinson. It's still a progressive disease. And actually, and some of those results were already shown. The only thing that do help to stop this disease is good physiotherapy. Keep moving in patients. You see that is of influence of the brain. So initiatives to improve people's movements, exercise, dancing. I think actually one of the most important things. I think from my point of view, I refer all my patients at least once to a good physiotherapist to work on exercise, because I think very important is this patient group.
Yes, of course, exactly. I understand the physiotherapy and the exercise, Graham, that you've been speaking of also. Do you think that the benefits come from the actual triggers in dance? Is that like the music perhaps, or the cues from the rhythm or something like that? Is that perhaps one of the reasons also for the benefits that you see? Perhaps Dr. Kalyani?
Yes, actually, I think there are a lot of the benefits are due to, as I mentioned, the things which are embedded in a traditional exercise program is also, we found those things in this dance classes, even though they are not therapeutic exercise classes. The components of balance exercises, for example, single leg standing with a support, such things are included in this dance classes. And also the other thing is it is a pleasurable experience for participants, rather than just going to exercise classes, having the mentality of having like they are a patient with a Parkinson's disease. Here they come to the dance class as a dancer, and also with sometimes the caregivers are also participating in the dance classes. So it provides a lot of psychological benefits, which ultimately reduces the anxiety and depression in those participants. And also, as I mentioned before, there are a lot of cues and which are used in these classes. For example, the music is a very strong auditory cue, and then there are visual cues. They can see others dancing, not like they're just doing the dancing at home, or like just doing it alone in a physiotherapy setup. They have a group of people, and also they can see the dancers, so they get visual cues, and also somatosensory cues, such as when they hold hands or holding the chair, so they get some sensory cues. So those things are of course encouraging and stimulating the improvement of the disease.
Yes, thank you, exactly. I have one question here. One of the elements that I have observed is that sometimes the clinical measurements don't seem to capture everything that happens in a dance class. Yeah, of course. What do you think about the idea of engaging in creative developments with clinicians and teaching artists to envision further means of assessment? And I guess we're talking the social side as well, and the well-being side, basically. Yeah, I don't know who'd like to answer that one.
I'll have a quick go at that, because I think that's really, really important. And Adisha has really nicely described those sort of effects of social environments that are important. And I think some of the people who come in, they make comments like, oh, I don't feel like I'm a person with Parkinson's anymore. I feel like I'm a dancer. I feel like I can communicate and I can express my thoughts and ideas to people in the room. And importantly, they can do that through movement and not just having to speak what they think. So it's the way you capture other forms of expression and communications with others, which I think is unique in the sort of dance therapy environments. How we capture that in a sort of quantitative sense is, of course, another matter. I think it's something really worth trying for. I think there are ways we can quantify expression and meaning within movement. So I think that's a really good way forward in terms of future research work. And I think critical to that is also the link with music. So it's what people identify with. So, you know, I might like some piece of classical music and somebody might like some piece of rock music and somebody might like some hip hop. It's about that personal identity person has with the theme that's going through. And of course, that also changes and improves the sort of social interactions that occur too. So I think all those elements are intertwined in some way.
Just muted myself. That, yes, exactly. And thank you. And I would be great to be able to quantify that. I agree. We were also just discussing how great it would be to for the potential for a study involving the shoes, TJ, and the dance class to see what the benefits of that would be.
Yeah, definitely would be awesome. I think also to give it to people while they're dancing.
Yeah.
Yeah. Maybe that's a good initiative for next year. Yeah.
Exactly. Are there any other questions? I'm not seeing too many come through in the chat. I don't know if there's anything else any of the speakers would like to mention again. Perhaps something that they missed in the class. Oh, hang on, I've got one coming through for Camilla. What challenges do you see with your communities in Brazil that might be different to other communities?
Thanks for your question, Erica. Yeah, so in Brazil during the project, we didn't have any funding. So we were able only to recruit participants who had a device and internet at home. And the majority of Brazilian population don't have access of a good device with a good sound quality and everything. So this was the biggest challenge for us, that it might be different compared to other countries. So yeah, I'd say the device and technologies were the biggest challenge in Brazil.
Yes, understandable. But also here too, I mean, technology is a difficulty for many people anyway. Yeah. Thank you, Camilla. I have a question here. Resistance exercise that Graham mentioned in a non-COVID environment, is a component of resistance dance movement within participants okay? For example, holding onto arms, connecting with a push-pull feeling, is that okay, or is it too dangerous with participants?
That is a very tricky question. I mean, certainly the exercises would be very beneficial, but I might hand over to TJ in terms of the clinical aspect and the risk management associated with that.
Yeah, well, I think I have the same answer as you with that. It sounds tricky to do, but yeah, people, I think they can benefit from it. But yeah, fall prevention is also a big thing, of course. So yeah, difficult one.
A bit risky, yes, perhaps. I have another one here. Given how much evidence is being generated that dance and other arts participation has a positive impact on health outcomes, why do you think there isn't more support for this approach in some parts of the medical industry? Gosh, who's going to take that one?
I think it's a very difficult one. Because it's a whole culture about how you approach the condition, and we need to influence the culture of our society in a way that is a much more acceptable way of being within our culture. It's not that I don't know multiple medical people who are not artists in their own rights as well as practitioners, so I'm sure there's no lack of willingness to have this sort of engagement, but it's the models that are used by government agencies in terms of how they, you know, I guess, compensate for treatment or have prescriptions, etc.
Absolutely. And there was just a, sorry, I didn't mean it to be a tricky question. That was from Elliot. Okay. Are there any more questions coming through? Just reading my screen. Research often involves lots of collaboration across sectors and actors. Do you have any suggestions about how to make this kind of collaboration successful? Any takers?
I always have thoughts, but I'd really like to hear from Nadisha and Camilla, perhaps, from their perspectives, having gone through recently and want to engage in a process of doing research studies.
Yeah, Graham. So I think it's really important to have collaborations between the dancers and also the clinicians and therapists in terms of making such research projects successful. So, for example, in my research project, I'm from a physiotherapy background, and I, of course, did not have many knowledge or any background in dance. However, it became a really successful as well as very interesting experience for me, going through this and learning and undergoing some of the dance courses at Queensland Ballet and getting familiar with this dance background, and also becoming a part of the dance PD community as a physiotherapist. So I see the comparison between just becoming a physiotherapist and doing just an exercise program for participants. And sometimes that is not very interesting, or they may not be adhering to the exercise program for long term if I just do an exercise program for them. However, I see a much more benefits when it is connected to these dance and music and everything, which became really enjoyable, pleasurable experience for participants. And also, I think the clinicians also should get involved in these type of research projects, so then the message can be conveyed to the patients in the proper way in order to not only just adhere to the medication, but apart from that, along with the medication, there should be some exercising, and especially this dance PD is really important to go along in their life with a patient with a Parkinson's disease. It's really important. So I think these collaborations are really important in terms of research and also clinical practice as well.
Yes. I think that leads probably on to the next question, which is artists often want to build better relationships and links with clinicians. Do you have any suggestions? Perhaps that's TJ.
Yeah, I get always. I'm very keen to get them in and get them involved. For example, I think what you need is just a good team and people who are keen to do research or do collaboration initiatives. For example, I know Graham sometimes visits us on Friday Clinic in Wynnum, and then not only he's seeing what we are doing, but we are also hearing from him what he's currently busy on. And for example, with PD Queensland, and now every Friday, once a month, sorry, not every Friday, once a month, they come on Friday, and also they are just sitting there, and our patients, we say, well, after they visited us, look, Queensland, Parkinson's Queensland is here today. You can walk in, you don't have to, but you can hear what kind of things there are, and that can be research thing, but also that, for example, yesterday I had actually an ex-professional boxer in my clinic, and I just heard from Parkinson's Queensland, well, we also do boxing lessons. Hopefully he's not a guy who is knocking out all the other Parkinson's patients in that class, but I think, yeah, getting in contact with each other helps us to referring our patients also to the right person, because I think there is actually quite a lot going out there, but some clinicians just don't know what there is, and then they yeah, and that's actually hurting our patients, I think. So yeah, and always happy to get involved. So also after this session, if people want to contact me or Alex, who's my supervisor here in PA, always happy to answer questions. Or if you want to participate in one of our clinics, you can always join. Yeah.
Thank you for that invitation. Okay, I think we may be taking just one last question. And this could be all of you or a couple of you anyway. If you could research anything next, no external parameters, what would you like to investigate next? Camilla?
Yes, so very good question. I think regarding dance research, we have so much things that we need to investigate, and some of them is really hard to measure. But one thing that is really nice, I'd say, maybe the socialization and the engagement of a dance group during a class. We can do that with measuring the brain activity and seeing how we can engage with each other. I think this is a really important benefit, the socialization, and we have some technology to measure it. I think this is the next step.
Yes, thank you. Professor Kerr, do you have any ideas?
Always lots of ideas, too many. But I'm really interested in the opportunities that the shoes that TJ described in terms of digital health for people with Parkinson's. So therefore your treatment and any aspect about your treatment is not necessarily confined to a clinic visit. It's actually there potentially 24/7, although I don't think the neurologist is going to be sitting at the computer all that time. But that opening for treatment and monitoring. And I also like to think, I want to understand what's happening in people's brains. So we've got mobile technologies now which can measure brain activity during everyday life. And so I'd like to combine these two elements. And the reason I say that is because I want to know when certain parts of the brain are actually improving and when they're not improving. And you can't get that by just lying in a brain scanner. You've actually got to have some sort of mobile technology in order to get at that particular question. And so I think those things will help to revolutionize treatment in the long term anyway.
Yeah, absolutely. So I think we're actually out of time, but I wanted to say thank you so much to all our presenters, Professor Kerr, Dr. Legrand, Dr. Kalyani, and Camilla, all the way from Brazil. Thank you all so much. It's been a really, I found it fascinating presentation. Thank you to all of you. I just will hand over to Erica Rose, who would just like to say a little something also before we pass on to the next presentation.
Thanks so much, Sue, and a big thank you. I'm giving lots of applause to all of the presenters, and for me, it was a great opportunity to continue learning about what's happening currently in the research arena, but also to continue to explore some of the research that's been happening around dance and Parkinson's. So thank you all. I think we're in this ongoing process of thinking of ourselves as it's a dance and an arts program. So when we envision Dance for Parkinson's, dance is at the center. But I think what I've always appreciated about the Dance for PD model and the work that David Leventhal has done from the United States is that from the very beginning, he was committed to building strong relationships with researchers, with clinicians, with health professionals, and that for everybody working together is what makes a program like this possible and allows us to engage in best practice and continue to I would say, evolve the field, develop this field of practice. Dance has been around for thousands of years, but the ways in which we use it and the ways in which we measure it, I think will continue to evolve. So thank you, everybody. Just a reminder, our next session is going to be a class. So we're going to have a 15-minute break. We're going to close the live stream. And if you want to join the class, it's going to be in the Zoom link. It's with Simone from the UK, and we're going to do a little popping for Parkinson's. So join on in. You might need to get your space ready so that you can move around safely, but we'll see you in the Zoom link. Again, a big thank you to all of our presenters. Thank you.
Thank you.